Assalamu alaikum. আমি শুরুতে একটু বাংলায় বলি তারপরে we'll get right into it. অর্গানাইজারদেরকে অসংখ্য ধন্যবাদ আমাকে আমন্ত্রণ জানানোর জন্য। সাধারণত শিক্ষকের সামনে দাঁড়িয়ে ছাত্র যখন কিছু বলে সেটা ছাত্রের জন্য খুব নার্ভ ব্রেকিং হয়। কামরুজ্জামান স্যার এখানে আছেন, উনি আমার শিক্ষক এবং ওনার সামনে দাঁড়িয়ে কিছু বলা আমার জন্য খুব বিব্রতকর, কারণ আমি জানি যে স্যার হয়তো ভুল ধরে ফেলতে পারবেন। তো তারপরেও আপনাদের ভরসায় বলছি, অসংখ্য ধন্যবাদ। So let's get started. Before I start, I'm going to talk about three things. My wife always says that I speak very quickly and fast, and if you find it hard to follow me, please let me know and I'll try to slow down. That's number one. Number two, if I'm going over time, someone please let me know and then I'll try to cut back and finish on time so that we can stay on schedule. And the third thing is, there is a difference between a conference, a seminar, and a preceptorship. If this was a conference or a seminar, then I'd be standing there while giving the talk. But a preceptorship is supposed to be interactive. And that's why I'm going to walk across the podium back and front. And that's really for my own comfort. But more importantly, I'd really love if you guys sort of interact, stop me, ask questions. If I'm saying something that doesn't make sense, feel free to put your hand up and we'll talk about it. Obviously, we'll happy to take as many questions as you like. I can take questions at the end. But for the sake of keeping it all interactive, just stand up or raise your hand and ask me questions. So I don't mind at all. So let's begin. I think I'm going to give two talks today. The first one is updates in early stage lung cancer, and the second one is updates in advanced lung cancer. It's amazing that a medical oncologist is being asked to talk about early stage lung cancer, because if you go back 10 years ago, there was really nothing for a medical oncologist to contribute in early stage lung cancer. So this is fascinating how far the field has come. Now, these are my disclosures, nothing really relevant for today's talk. So I often show this slide in different conferences or talks, or even whenever I'm teaching medical students, and this is really to make a really interesting point. You don't really need to look into the actual slides, but these are two stage 4 lung cancer trials reported 20 years apart. So the left one was metastatic lung cancer patients given single agent or double agent chemotherapy and looking at their overall survival. The right one is Keynote 189, published in 2023, so essentially 20 years later, same patient population, metastatic lung cancer patients given either chemotherapy or chemotherapy plus immunotherapy, and showing how long they have lived. Now, everyone here is a medical oncologist or is an oncologist, radiation oncologist or clinical oncologist, so I really do not need to explain a survival curve. So everyone knows that if the curve moves to the right, that means the patient is living longer. That's essentially what we look for, right? So we give the patient a treatment, the curve moves to the right, that means that the median survival is increasing, the patient is living longer. For me, that is actually not the advance in lung cancer in the last 20 years. When people talk about advances in lung cancer, they think that the fact that the patients are living longer now compared to how long they were living 20 years ago is the biggest advancement. But that's actually not the exciting part. The exciting part is somewhere else. Let me explain. So I really want all of you to focus on the 3-year mark here. So 36 months is the 3-year mark, and these patients, at the end of 3 years, there is no one alive. Everyone's dead, right? So that's a very clear finding. Now look at it here. So this is Keynote 189, patients given chemotherapy plus pembrolizumab, and obviously they're living longer. But look at the 3-year mark, so 36 months, 31% patients with chemo plus immunotherapy are still alive. That's also not the interesting part. The interesting part is, if you look at the chemotherapy arm, there is also 17% patients are alive at the 3-year mark. 14% patients are alive at the 4-year mark, and so on and so forth. So the same group of patient, at the end of 3 years, everyone was dead, but the same group of patient, not even immunotherapy, just chemotherapy, there, at least 1 in 5 patients are still alive at the 3-year mark. So it's not that we have pushed the curve to the right, but the fact that we have pushed the curve upwards is the biggest advancement in lung cancer in the last 20 years. So not just people are living longer, but there is a significant group of people that are potentially being cured of lung cancer, stage 4 lung cancer, which is the most amazing part. And why would 1 in 5 patients with stage 4 lung cancer with chemotherapy still be alive at the 3-year mark when they were all dead 20 years ago? And that is because now we have a much better understanding of patient selection. So arguably there were a lot of mutant patients included in that trial without actually being known. So there might be patients who were EGFR mutant or ALK mutant or RET fusion positive. They were all clumped together without being known. Whereas now you're selecting out patients much better. You know, you've incorporated NGS as part of your regular clinical practice, and therefore you're selecting out patients that you know that needs chemotherapy. You're selecting out patients that you know will benefit from immunotherapy. And you're selecting out patients based on your NGS, as we have heard earlier today, that you're going to give targeted therapy or whatever. And that's why, because you're selecting patients better, that is why your patients are doing better now as opposed to how they were doing 20 years ago. So for me, that's the most exciting part in thoracic oncology. Now, we have talked about a few things, or we have heard about a few of these things earlier today, so I'm not going to go through all of them. But that's just a brief sort of summary of some of the things that we're going to cover. Now, I'm preaching to the converted. Everyone here is an oncologist, so I really don't need to tell you how the lung cancer patients present or how they need to be investigated, et cetera, et cetera. There is really a couple of points that I want to point out in early stage lung cancer, or any lung cancer for that matter. 10 to 15% of lung cancer patients have never smoked. So that is an important take-home message. There is still obviously a lot of stigma around lung cancer and smoking, which is rightfully so, but we also need to be aware that a significant group of people with lung cancer has never smoked. All the more reason to do NGS, because these are likely to be the group of patients that carries some sort of driver mutation. So these patients are super important to have a much better understanding of. Now, early diagnosis is the key. We all know that, so I'm not going to sort of ponder on that for too long. Diagnosis. When it comes about early stage lung cancer, diagnosis is the key, because you've only ever got one bite at the cherry. If you don't get it right the first time, everything that follows after that initial staging and diagnosis is going to be incorrect. And lung cancer, or any cancer for that matter, you can't really afford to do that. So you have to get things right at the beginning. And obviously staging scans are important. We all know about CT scans and PET scans and MRI brains, because brain's a sanctuary site, and all those sort of things. I'm going to harp on two things really. One is, when it comes to early stage lung cancer, nodal staging, or the status of your mediastinal lymph nodes, are absolutely important before you make your treatment plan, because there is a lot of data out there to show the discordance between your clinical staging and your pathological staging, meaning that the PET might be negative for your mediastinal nodes, but when you actually interrogate those nodes with EBUS or whatever, you might find that the disease is actually upstage. So nodal staging is important. The second thing is about PET scan. We have heard about PET scans earlier today, and it's the gold standard for lung cancer staging. However, we also need to be aware that PET scan is very sensitive, but it is not specific. So the sensitivity of a PET scan reaches almost 100%, but the specificity lies somewhere between 60 to 92%, depending on whichever literature you're reading, meaning that if something looks like lung cancer on a PET scan, it might not be necessarily lung cancer until you've done a tissue diagnosis. These 3 patients are my own patients. I've just sort of given them as an example. The patient on the left-hand side, very strong smoking history, a left upper lobe changes, which is FDG avid on a PET scan, so clearly looks like a PET scan, looks like a cancer. The biopsy showed it was a cryptogenic organizing pneumonia or something along those lines. The second one, quite a solid-looking, very FDG avid lesion in the right upper lobe. On biopsy, it was sarcoid. The third one, similarly, solid lesion in the lung, looks, at least on morphology, looks very concerning on a CT scan. Again, FDG avid on a PET scan, but biopsy came back as a sclerosing pneumocytoma. So really just to be aware that if just because something looks like cancer doesn't mean it is cancer until you've done a tissue diagnosis, whether it's a CT-guided biopsy or something else. So just be aware of the limitations of the PET scan. Next thing is patient selection. So obviously we're talking about early stage lung cancer, so essentially by definition between stage 1 to stage 3, or if we subdivide it, we are going to talk until stage 1A to stage 3B, because, or 3A I should say, because 3B really shouldn't be operated on. So 3B, chemoradiation followed by immunotherapy, Pacific trial, that's a different story. 3C, essentially, you treat like a stage 4 cancer, and stage 4 is stage 4. But in early stage lung cancer, establishing the staging is absolutely important. We've talked about nodal staging. So nodal staging is important because of 2 things. The first thing is, we have heard about the TNM staging earlier today. What you really need to be aware of is the TNM staging, the edition has changed over the last 10 years, right? So it used to be AJCC 7th edition, which a lot of the neoadjuvant lung trials used. Then came the AJCC 8th edition, which is the edition that most of the adjuvant trials used. We are currently in the 9th edition, and we have heard about the 9th edition. The main difference from an oncology point of view between the 8th edition and the 9th edition is that the end staging has changed. So in the 9th edition, you've got N2 has become N2A or N2B, meaning that you have either got a single station N2 disease or a multi-station N2 disease. So a multi-station would be N2B and a single station would be N2A. Why is that important? The reason being, the surgical outcome is different between, and I'm going to show you some data in a minute, but the surgical outcome, the surgical mortality, the 30-day postoperative complication rate, and most importantly, your disease-free survival or DFS changes if you move from N2A to N2B. However, it's almost impossible to interpret the clinical trial data to bring into your clinical practice, because most of the clinical trials that have been done in the neoadjuvant or perioperative setting, they have either used AJCC 7th or the 8th edition. So you can't really extrapolate your trial data into your clinical practice. So if you've got a patient that walks into your clinic tomorrow and it looks like it's a T2A N0 or N1 disease, you can't really not interrogate the mediastinum to establish whether this is a single station or multi-station disease, because none of your adjuvant or neoadjuvant trials are downstaging trials. So these cancers have to be operable to begin with. So it becomes very complex. So nodal staging is absolutely important. The second point we'll talk about in a minute is operability. So the cancer could be operable, but is the patient operable? And selecting the right patient is also very important, and we'll touch on that in a second. The third thing is the type and quality of surgery. And by type and quality of surgery, I do not mean how good the surgeon is or how experienced the surgeon is. That's not what it meant. It means that there is a clear distinction between a lobectomy, a segmentectomy, and a wedge resection. And depending on the tumor location, the primary tumor location, A segmentectomy might be as good as a lobectomy, again, depending on the situation. But a wedge resection might be suboptimal. So the type of surgery is important. And the quality of surgery means the amount of lymph nodes that are harvested at surgery can be optimal or suboptimal. So for example, if your surgeon only takes, let's say, a station 10 and a station 12 node, so 2 nodes taken out at surgery, one from station 10, another one from station 12, and both of those nodes are negative, is it enough to say that you can confidently say that this patient is node negative? So the consensus guideline is unless you have harvested at least 5 nodes, and depending on which side of the lung, or whether the right-sided or the left-sided tumor, you at least have to take a station 7 sample, a station 10 sample, possibly station 4. So there are some very clear guidelines depending on which side of the lung the tumor is. Unless there are 5 nodes harvested, it would be considered a suboptimal surgery. So the nodal status, defining the right patient, how many nodes have been sampled, and which station of nodes they have been sampled from are all very, very important. And obviously the last thing, and we are going to talk about the role of adjuvant and neoadjuvant and perioperative drugs and how that has changed the lung cancer practice in recent times. MDT discussion or multidisciplinary team discussion is absolutely very important, and I'll show you some interesting data about that too. Is everyone following? Am I going too fast? Yes, no? Yeah, maybe? Okay, happy to keep going? Yeah, all right, thank you. So, nodal stations. I'm not a thoracic surgeon. I can't remember it, so I've got this picture on my wall in my office so that I can remind myself all the time. There is a very easy trick to remember. If the nodal stations are single digit, so 1 to 9, they're all station N2 disease, and 10 and above. So if it's a double digit number, then it's an N1 disease. So that's how I remember it. And single station N2 is N2A, and multi-station N2 is N2B. That's the main difference in the 9th edition. As I said, it's not projecting very well, but very recent data, it came out in February this year. It compared the patients between the 8th edition and the 9th edition. So in the 8th edition, there was only one group, which is the N2 group, and they obviously did better than the N3 group, but they did worse than the N1 group. But that's sort of, you'd think that intuitively. But on the left-hand side, obviously you've got the N2A and the N2B, and the N2B patients did much worse than the N2A. So which means that you've got a single station N2 disease, then you're going to do better than multi-station N2 disease. Some thoracic surgeons even argue whether we should be operating on multi-station N2 or not. There is a lot of debate. That's something that we are all debating very actively at the moment. And there are some ongoing downstaging trials that are currently recruiting, but until that question is answered, we really don't know whether multi-station N2 disease should be operated or not. And that's probably where neoadjuvant treatment plays a big role. So just to make you aware that it's very important to understand the status of the mediastinal nodes before you commit someone to surgery, because thoracic surgery is a big deal. Operability, I touched on it a little bit before. So the tumor might look very operable on the scan, but whether the patient in front of you is operable or not, obviously as part of your preoperative assessment, you'd be doing lung function tests, echocardiograms, 6-minute walk test, all those sort of things. And sometimes those sort of numbers give you a good idea of whether this patient is a good surgical candidate or not. Sometimes just the end of the bed assessment is enough to say that the patient is operable or not. If the patient comes in on a wheelchair, huffing and puffing, you know that this is not a surgical. But if there are patients who are borderline, you've put the patient through the works, you've done the echo, you've done the lung function test, you've done the 6-minute walk test, and all those sort of things, and you still can't decide whether the patient is a surgical candidate or not, then a formal cardiopulmonary exercise testing is the gold standard. So that's the test. I don't know whether it's available here or not, but a formal cardiopulmonary exercise testing is a good way of knowing if this patient will have increased or a higher or a lower postoperative complication risk, and that's what I've written there. Patients who are still borderline on the CPET, and you think that, yes, you really want to operate on this patient, but you've got a little bit of time, maybe 3 weeks before you can take them to theater, then prehabilitation, not rehabilitation, prehabilitation is a good way to build up the patient's physical fitness. Obviously, stopping smoking is very important. Within 2 weeks of someone stopping smoking, the ciliary mucus secretion actually drops quite significantly. That increases or that decreases the risk of post-op pneumonias and those sort of things, or atelectasis, etc. But there are other structured exercise programs that can be done in the pre-op or prehab setting to make that patient fitter before you take them to surgery. So there is something to think about. Now, you've diagnosed the patient, you've operated on the patient, and the patient's done well. The next step is what to do, whether or not to give them adjuvant chemotherapy. Now, this debate has been settled for some time. The LACE meta-analysis came out almost 20 years ago. It shows a very small survival benefit of adjuvant chemotherapy in resected stage 2 and above lung cancer. So 5% over 5 years, 4.6 to be precise. So a small benefit of adjuvant chemotherapy. We all know that, so there is no sort of debate around it. Next step, which is the recent advance. How am I going for time? Another 10 minutes? 10, 12, okay, 15, perfect. So neoadjuvant, adjuvant, perioperative. I've been lucky. These are the 3 pivotal trials in this setting. I've been lucky to have been the principal investigator for 2 of them. I was part of the investigator team for Empower 010. I'm one of the authors for Checkmate 77T. So if you only want to know about 3 trials and nothing else in perioperative lung cancer, then just read up these 3 and nothing else matters. Checkmate 816 is a pure neoadjuvant trial, which means that you give the patients some treatment before you take them to surgery. Empower 010 is a pure adjuvant trial, meaning that you have operated on the patient, you've given them adjuvant chemotherapy, and then you give them adjuvant immunotherapy. And Checkmate 770 is a perioperative trial, meaning that you give them some treatment before surgery, then those patients go and have their surgery, and then you give them something after surgery. So that's a perioperative. So these are the 3 settings. So we'll briefly run through them. Checkmate 816 is if you want to sort of take home one message tonight about adjuvant or neoadjuvant treatment in lung cancer, this is it. So Checkmate 816 is the only study in resectable lung cancer that has a reported survival benefit. So no other perioperative adjuvant or neoadjuvant lung cancer trials have survival that has been reported yet. This is the only one. And it shows that there is a very clear survival advantage if you give these patients 3 cycles of neoadjuvant chemotherapy plus nivolumab. So only 3 cycles. And that's really good, because if you're going to take the patient to surgery in 4 to 6 weeks' time, then that actually gives you enough time to get 3 cycles of treatment in. And 3 cycles of chemo plus nivo doesn't really have a lot of toxicities. You are unlikely to create too many problems that might jeopardize the patient's chance of having surgery, and I'll show you the data about that. But 3 cycles of neoadjuvant nivo plus chemo, the median survival hasn't been reached yet, but in the chemotherapy arm, it's 73 months or 78 months. Now, obviously, if you're going to tell the patient that you've got a resectable lung cancer, however, we are not going to cut it out, we are going to give you some treatment before you take you to the theater, it creates a lot of anxiety in the patient and the family. So they know that you've got a resectable lung cancer. You can take it out now if you want to. However, you're not going to do that. You're going to give them 3 cycles of treatment and then take them to theater. The first question the patients will always ask is, what are the chances that I might not get to surgery? And that is exactly the question they asked here. So in Checkmate 816, 16% patient in the Nivo chemo arm had surgery canceled, and 21% patients had surgery canceled in the chemo arm. So basically, 1 in 5 or 1 in 4 or 1 in 6. And the main reason being the disease progresses in that time, and the others are administrative or adverse reactions, etc. So when we talk to patients about this approach, it's about balancing out and a lot of things. And this is where it becomes interesting, because the science of oncology might be the same, but the art of oncology is different between oncologists. It's really about how you interpret the data, how you explain that data to the patient and the family in front of you, and the buy-in of your thoracic surgical colleagues into this approach. You cannot do neoadjuvant treatment unless you've got your surgical colleague on the same page as you are, because it's a collaborative effort. So if anything, there is a bit of reassurance there that not a lot of patients had surgery canceled because the disease had progressed. Only 10%, so 1 in 10 or 1 in sort of 11 patients had the disease progressed while they were having neoadjuvant treatment. This is super exciting, and this is coming soon. So ctDNA clearance. So ctDNA, I'm sure everyone here knows, stands for circulating tumor DNA. So when you've got a tumor sitting inside you, the tumor constantly sheds fragmented tumor DNA in the bloodstream that you can actually detect through a blood test. So when you give someone neoadjuvant treatment, you can actually measure their ctDNA serially and see that the ctDNA drops. As the tumor shrinks, as the tumor goes up through apoptosis, the shedding of the ctDNA drops. And if someone has their ctDNA dropping, then you actually do know that the tumor is responding because the ctDNA is clearing. And what this showed, it's not really projected very well, so I really do apologize for it, but it basically showed that even within the chemo plus Nivo group, patients who had the ctDNA cleared lived longer compared to patients who didn't have ctDNA clearance after the end of neoadjuvant treatment. So this is a fantastic surrogate biomarker that's coming in the coming years, where luckily we use it in routine everyday practice where I work, but globally I think obviously it's going to come very soon. This is another interesting one. There is, we talk about pathological complete response when a lung cancer gets resected, and what it actually shows, this thing shows 2 things. It shows that if you've got a ctDNA clearance, it does not necessarily mean that you will get path-CR. However, if you get ctDNA clearance and you get a path-CR after your neoadjuvant treatment followed by surgery, then your chances of 5-year survival reaches almost 100%. So that is another take-home message, that you could use path-CR and ctDNA clearance as prognostic and predictive biomarkers for your 5-year survival. But interestingly, not everyone who gets a ctDNA clearance gets a pathological CR. So there's a lot of more work to be done in that space. Empower 010, surgery first, then 4 cycles of adjuvant chemotherapy, and then those patients were given 12 months of adjuvant atezolizumab or nothing. So purely adjuvant immunotherapy. 3 things it really showed. Stage 3A does better than stage 2B. That's the arrow. N2 disease did worse than N1 disease. And all adjuvant chemotherapy works well except carboplatin and gemcitabine. So if you're choosing an adjuvant chemotherapy in this setting, you can choose carboplatin and vinorelbine, pemetrexed if it's non-squam, but don't choose carboplatin and gemcitabine because that's inferior. And that's what this shows. Checkmate 77T, these patients, stage 2 to stage 3 disease, got 4 cycles of neoadjuvant chemotherapy plus Nivo, then they had surgery, then they had 12 months of either Nivo or placebo. Obviously, the Nivo group did better. The arrows are, it shows that the multi-station disease actually did better than the single-station disease, meaning that if you've got a high-volume nodal disease, then this might be a better approach because you're potentially downstaging the cancer, and that's possibly why they are doing better. And the other thing is, if it's PD-L1 more than 50%, then those patients do better than compared to PD-L1 1 to 49%, but that's, again, to be expected. So there is some signal in this trial that high-volume N2 disease, there might be, perioperative might be better than just pure neoadjuvant or adjuvant. I'm not going to spend time on this. Driver mutations, so obviously everything that I've said so far assumes that the patients are not EGFR ALK mutated, but in the adjuvant setting, you've got your ADAURA trial, which is adjuvant osimertinib for 3 years. You've got your ALINA trial, adjuvant alectinib for 2 years, and then Libretto 432, which was presented earlier this month at ASCO. I was an investigator on Libretto 432, so adjuvant selpercatinib for 3 years for RET fusion positive cancers, and they all did well, but that's again to be expected. If you've got a driver mutation, you've removed the tumor, give them adjuvant targeted treatment after you've, or all these trials had the option of giving them adjuvant chemotherapy followed by the targeted treatment, and they all did significantly well. Just a couple of slides just to sort of give you some interesting thoughts. MDT, or multidisciplinary meeting. So patients who are discussed in a multidisciplinary meeting live longer compared to patients who are not discussed in a multidisciplinary meeting. It essentially says that 2 or more brains are better than 1. So no one's perfect, no one knows everything. So a collaborative, collegial approach where you debate and discuss a patient always gives the patient a better outcome. And I always show this slide purely out of interest because my mother is a breast cancer patient, and despite having a PhD, she looks up YouTube videos and does a lot of funny things. And I'm sure your patients do, and my patients also come into clinic every day, and they bring in weird and wonderful stuff that the source of the internet. And it just shows that if you use non-conventional alternative medicine in oncology, your risk of dying goes 2.5 times higher. I've shown this slide to my mother, didn't work. I'm showing it to you in case it helps you. So yeah, so I've got my last slide after this, and this is the most exciting part. This is the second last slide. So when we talk about early stage lung cancer and what is the biggest advancement that is coming in early stage lung cancer, the question about adjuvant, neoadjuvant, perioperative is almost being sort of answered. So what's the next step? The next step is tumor vaccines. Now, when I show this slide to my medical students, they get very confused. And the reason being, vaccines in conventional sense is not the same as vaccines in the oncology sense. So in a conventional sense, when you talk about vaccines, you think about giving a measles vaccine to the whole population of all the children, and therefore they do not develop the disease. But in the lung cancer world or in the oncology world, a tumor vaccine is not a preventative treatment. A tumor vaccine is meant for, one vaccine is meant for one patient and not anyone else. I'll explain. So you've got a stage 3 lung cancer patient, you've given them adjuvant chemotherapy, or you've given them neoadjuvant chemotherapy, whatever, they had surgery, you've removed the tumor, the patient hasn't had pathological response, so there is, or hasn't had pathological complete response, so there is residual tumor tissue left. So what you do, and this is what we are doing at the moment, I'm running a V940 trial which is testing this. So you take surgical tumor material from the surgical specimen, you sequence the tumor, you identify the epigenetic epitopes of that particular tumor, and then you develop a vaccine of that particular cancer. So the vaccine that is developed is against that patient's cancer. And then once you've made that vaccine, you inject it back to the patient, train the patient's immune system to become active and able to detect if there was a recurrence of that particular cancer in that particular patient in the future. So a tumor vaccine, one vaccine for one patient, is not meant for conventional mass use. It doesn't prevent cancer. It prevents but the idea is it will prevent the recurrence of that particular cancer in that particular patient in the future, should that happen. So that is the concept of tumor vaccine. A lot of work being done, really at the cutting edge, coming in the next 5 years, maybe even sooner, so watch the space. And that's my last slide. Thank you.